This week, we are going to talk about clinical management of large periapical lesions. If you're new to the channel, my name is Siju Jacob. I've been a private practitioner for the past 25 years in Bangalore and Dubai. I've been using a surgical microscope in my private practice for more than 20 years, and I've been training dentists how to incorporate the surgical microscope in everyday clinical practice for more than a decade. If you've been here before and you found some value in the videos that I post every week, then don't forget to click on that subscribe button so that you get notified every time I upload a new video, which is usually every Sunday. You can also subscribe to my weekly newsletter. I've put the link in the description below so that you get even more useful information delivered right into your inbox every week. As clinicians, we are exposed to different kinds of periapical lesions. Fortunately, most periapical lesions can be managed in-house in a very straightforward manner. However, there are some periapical lesions which require different kind of management than what a dentist can offer in everyday clinical practice. So when we talk about periapical lesions, you can have a large variation. The most common ones that you see are something like this, where you have a small apical lesion in relation to one tooth. Somebody's done an access here, so we go there, do an obturation, and then 1 year later the lesion heals non-surgically. This is something very common. And then you can have a larger lesion. The primary cause of this again is endodontic. So once you treat this non-surgically, the lesion heals. The 3-year recall shows the lesion heals. And then on the other hand, you have extreme cases like this, where treatment of this lesion on the left side of the mandible involves the resection of the entire left side of the mandible. So how does one figure out whether or not an apical lesion can heal like this conservatively just by doing conventional endodontics, and then which case requires resection of the entire mandible? This is something that every practitioner needs to be aware of. So this short video is my attempt to provide some sort of a guideline for a young dental practitioner, or even an older dental practitioner for that matter, as to what to do when faced with a periapical lesion in your clinical practice that doesn't follow what we usually see in clinical practice. The discussion points that we will cover in this lecture are the types of lesions, the differential diagnosis, when to take a biopsy, and then we'll probably look at some clinical cases as well. So let's start with classifying periapical lesions. What are the common periapical lesions that we see in everyday clinical practice? Periapical lesions can be broadly classified into lesions of endodontic origin, which is inflammatory. Then you have non-inflammatory cysts, and then the third category is neoplasms. This is a broad classification. Lesions of endodontic origin are the most common, and the common ones are abscess, granuloma, and cysts, and there's no way to figure out which of these are just by looking at a radiograph. You need to take a biopsy. Then you have the fourth category, which is scar tissue. Condensing osteitis is not radiolucent most of the time, so I put that as a separate category. Most common are these three variations, which are primary inflammatory in origin. And then you have scar tissue, which some people say doesn't exist, is just a healing lesion, but some people insist that it exists. But we'll leave this out of it for now. Our current dilemma is with these three variations. Then you have non-inflammatory cysts, which is non-odontogenic and odontogenic cysts. Under non-odontogenic cysts, you have nasopalatine and simple bone cysts. And then under odontogenic cysts, you have keratocyst, lateral periodontal cyst, and calcifying odontogenic cyst. Out of which keratocyst is the most dangerous in terms of very, very high recurrence. So the treatment for odontogenic keratocyst is usually a little more aggressive than the rest. That's why I put that in red. And then, of course, you have the neoplasms, which are divided into benign and malignant. This is the list of neoplasms that you commonly see. And even though these two are benign jaw lesions, that is central giant cell granuloma and ameloblastoma, I've put that in red because these have a very high rate of recurrence and the treatment for these are usually very aggressive. Then, of course, you have the malignant jaw lesions, which obviously are malignant, so that require extremely aggressive forms of treatment rather than conservative forms of treatment. So this is a broad classification. So the clinician has to do the following steps when they are faced with a case which has a periapical lesion. So step 1 is to establish whether it's a lesion of endodontic origin or not. If not, then you have to refer. Step 2, if the answer to this is yes, which means you're sure that it is a lesion of endodontic origin, then of course you have to treat this in your own clinic. You can either treat it non-surgically or surgically. There are like different methods available in your clinic itself. Then, of course, you can proceed provided you've established that it's a lesion of endodontic origin. And then step 3, after you've done treatment in your clinic, you have to recall and then determine if further treatment is required. Let's say you've kind of figured out that it's a lesion of endodontic origin, you go ahead with some treatment, and then you recall the patient and you find out that the lesion is not responding, then again you have to ask for additional help or refer the case outside. So these are the 3 steps that a clinician needs to do. Let's look at the first step. How do we establish whether it's a lesion of endodontic origin or not? You have to primarily rely on history, clinical examination, radiographs and CBCT, and then of course histopathology if a biopsy is involved. But to me, the most important among all these factors is actually the clinician's experience, because once a clinician has spent a certain number of years in clinical practice, he or she will have a much better idea as to what is normal and what is not normal. So they will immediately know when they see a lesion which doesn't follow a set trajectory of some lesion which is atypical, they are immediately able to see it. It's a little more difficult for a beginner. That's why I think people who are starting off in practice should take the opinion or take the help of someone senior who's been around for a few years. They can spot these so-called zebras or the atypical cases when they see them in clinical practice. So clinician's experience is the most important. They have a saying, if it looks like a duck, swims like a duck, and quacks like a duck, then it's probably a duck. So when you see a case that follows certain set patterns, you have a non-vital tooth, you have a lesion, you could take a cone beam CD and you see a missed canal or some reason for why that root canal failed. Things like these stack up, and then you come to your diagnosis. So the majority of the time when you see a periapical lesion, it's usually an inflammatory lesion which can be handled in the clinic itself. The exceptions are the ones which are something else and something more severe. So example like this, you see a lesion on the buccal surface of maxillary molar, you put a gutta percha cone into the sinus tract and it leads into the mesobuccal root. You take a cone beam CT and then you see that there's a missed canal here. So all these 3 factors combined together tells you that this particular lesion is probably from a missed MB2. So the treatment for this is conservative. You go in there into the tooth, you find the missed MB2, you clean the canals, MB1s and MB2, you fill it up, you obturate it, that's how it looks, and then the lesion disappears by itself. So this is what we usually see in routine clinical practice. However, there are some variations, and this is another variation which you can see, rare, but it can happen. So when you see something like this, you have a hard bony swelling and there's expansion of the cortical plate, and then to take a radiograph, this is courtesy Dr. Lance Snyder, and you see lesion here, lesion here, lesion here. This is atypical. This is not something that you see very often. So it should immediately raise a red flag. And then you need to ask for a biopsy. And in this case, Dr. Lance has asked for a biopsy, and biopsy turned out to be osteogenic sarcoma, which is very, very different from an endodontic lesion. So that's how you go about it. So the next question is, when does one ask for a biopsy? Again, the directions are not very, very straightforward, because on one hand, if you start doing biopsy for virtually every case that comes to your clinic, every periapical lesion that you see in clinical practice, then you'll end up doing biopsy for every single case. And a biopsy is a surgical procedure. So it's not that easy to get a biopsy from a periapical lesion. So it will be a form of overtreatment if you start asking biopsy for every single case. And on the other hand, if you don't do a biopsy, then you have no accurate diagnosis. So one has to walk a fine line. So there are some guidelines which you can probably rely on. And let me show you some of those guidelines. These are just a short list. It's not an absolute list. There are other reasons as well. But by and large, these are some of the guidelines you can use as to when to take a biopsy. Lesion adjacent to root apex of white of teeth. So this case was referred for endodontic therapy of this tooth. And once I did a cold test, I found that it was responding immediately. So now you have a lesion in relation to a mandibular second molar, but that tooth is vital. So that should immediately raise a red flag. And this case will need a biopsy to find out why is there a lesion in a tooth which is vital. Persistent or progressively enlarging periapical lesion in relation to endodontically treated tooth or teeth. Now here's a case where on the right side, multiple teeth have been endodontically treated. There's a tooth which has been extracted. And in spite of all that, the patient has a large diffuse lesion. Again, it's an indication for a biopsy because this is not something that you see in everyday clinical practice. So that should immediately raise a red flag and one should ask for a biopsy. And in this particular case, the biopsy turned out to be odontogenic keratocyst, which required a much more aggressive form of treatment. And you can see here, that's the line of treatment. And this is like a 3-year recall. And you can see the treatment is more aggressive, which involves extraction and curettage of the entire lesion with a fairly safe margin as well. So it's much more aggressive. Another indication is multiple lesions in the same patient. So you have a case like this, you have one large lesion here, another large lesion here. It's extremely unlikely that this is going to be something inflammatory or endodontically related. It has to be something else. And the only way to find out what that is to do a biopsy. This is courtesy Dr. Marho. And in this case, it turned out to be calcifying odontogenic cyst. And this is a pretty conservative management. It involved only extraction of one tooth and the rest were kind of conserved with endodontic therapy. Another indication for biopsy would be irregular radiolucency. So when you say irregular, it means something like this. You can't call this regular radiolucency. The borders are kind of irregular. Again, it's an indication for biopsy. Another indication is lesion in relation to a teeth with minimal or no caries. In this case, you can see the left mandibular second and third molars are both vital. And there's no caries at all. There's not even a slight lesion. So here you have a large lesion and there's absolutely no caries at all. So why should there be a large lesion like this in relation to a tooth with absolutely no caries at all? So obviously it can't be an endodontic lesion. There has to be some other reason. So again, a good case to take a biopsy in this particular case. Another indication is the patient has sensation disorders. Patient comes to you and say, "Doc, I can't feel the right side of my face anymore." Again, we take a radiograph and we find out that there's a big lesion on the left side which has led to paresthesia. So again, an indication for biopsy, because it's very rare that somebody just pops up one day with paresthesia and it's because of an endodontic lesion. It's usually something else, some other pathology. So again, a good indication for biopsy. Advanced mobility without periodontal disease, again, a good indication for biopsy. This is courtesy my friend Dr. T.V. Narayan. You have a case where all the mandibular teeth are mobile and all the maxillary teeth are not mobile. So again, atypical, right? You hardly find a situation where somebody shows up with a lot of mobility in the lower teeth and absolutely no mobility in the upper teeth. So when one looks at the OPG, you can see there's a big difference between the maxillary teeth and the mandibular teeth. Again, this is something different. So one is able to spot a red flag and say, hey, this is not something that you see in everyday clinical practice. So let me look at a biopsy. Right? So these are some clues, and in this particular case, Dr. Narayan's case, it turned out to be something rare, which is Langerhans cells histiocytosis, which is very different from endodontic or inflammatory lesion. Let me quickly take you through a few clinical cases so you kind of have a rough idea about how the thought process works in everyday clinical practice. Again, like I reminded, this is not an absolute guideline. It's just a suggestion. You can use clues from this video to sort of nudge you in the right direction. This is a complicated topic, so it's not like you should take this video as gospel. One should use your own common sense to kind of nudge you along the right direction. Okay, so these are some clinical cases. Let's say you have a case like this, pretty large lesion. So what are the things we look for? Is this tooth non-vital? Yes, it is. It has a very deep cavity. The tooth is non-vital. There's a large lesion. It's pretty well defined. It's not irregular. The adjacent teeth are both vital. So all these put together, what's the likely reason in this particular case? It's probably an endodontic inflammatory lesion. So the treatment for this is non-surgical endodontics, which is what we did. You can see here there's lots of bone destruction there. We treated this case with multiple rounds of calcium hydroxide through a period, and you can see here after 5 months of calcium hydroxide there is a dramatic reduction in the lesion here, and then we obturated this tooth, and you can see a 3-year recall here where the lesions healed completely. So you can pre-op, and 3 years later this lesion is healed conservatively with just endodontic therapy alone. You can see the CBCT, that's the pre-op CBCT, and there's a 3-year recall CBCT. You can see the lesions healed completely. This is a case courtesy Dr. K. Nagesh from Bangalore. You can see here, this was referred to me. I was working in his clinic at that point in time. And the reason for referral was that the clinician felt that there's a lesion here in relation to the mandibular second molar. So I was requested to do an endodontic therapy of this tooth. Once I did a pulp vitality testing, I found that it was vital. It was responding to cold. And that again is a red flag. So I asked this patient to go in for a biopsy. The patient didn't listen. The patient wasn't convinced because he was informed by somebody else that you just need to do root canal for this tooth. So he was kind of confused, and then he showed up after 6 months where it had become even more diffuse by the time. So that's the problem in leaving these cases without biopsy. It can expand very fast. So we did a biopsy here, and then he found out that it was a keratocyst. So we did aggressive treatment for this. This is the post-op of this particular case. So one has to take a biopsy when one sees something out of the ordinary, and vitality is a good example. So if you see a lesion in relationship to a tooth which is like vital, then immediately one has to raise a red flag and suspect something which is different from a routine endodontic case. Here's another case, courtesy Deepak Nair, who's a friend of mine, classmate of mine, who's currently in the US. He had a case where the patient came with a large swelling on the left side of the mandible, and the OPG shows you a very large diffuse lesion, which is again very uncommon. You don't see this in routine clinical practice, right? So the minute you see this, you ask for a biopsy, and which is what Deepak did, and it turned out to be ameloblastoma in this case. So when you have ameloblastoma, again, the treatment has to be very aggressive. In this particular case, it's mandibulectomy or a partial mandibulectomy. So the entire mandible on that left side has to be resected out, which is what he did. And then there's a rehabilitation with implants in place. So now again, this is a very large lesion from canine to canine. But when one looks for a cause of this, you can see the location of the lesion is in the maxillary anterior edge area, and it's extending from the canine to canine. And you have 2 teeth which are non-vital, which means the child gave a history of trauma, and this tooth has become non-vital over a period of time, and then a lesion has formed in the central incisors and then expanded. So again, you have something quite obvious there. So in this particular case, the diagnosis is it is most likely an inflammatory lesion. So we go ahead with calcium hydroxide. In this case, you can see these two are not formed. Apex is not yet formed, whereas the rest of the teeth, the apex is formed completely. So in this particular teeth, we did long-term calcium hydroxide. You can see the adjacent teeth, the apex is fully formed, and these 2 teeth, the apex is not formed. So that again gives you a clue that this is the etiology. So the treatment for this is conservative, which means we did non-surgical endodontic therapy, long-term calcium hydroxide, and you can see over a long period, the entire lesion is healed, and that's the post-op. And you can see here, that's the apexification in addition to the lesion healing. So that's how we started, and this is how we ended in both these teeth. So the apex also has closed and the lesion is healed. So conservative management in terms of pre-op and the post-op, you can see the lesion healed with just endodontic therapy of these 2 teeth. Very different from the earlier case. This is another case which was misdiagnosed. It was sent to me for endodontic therapy of both these central incisors. The previous clinician accessed both these teeth. In one teeth, they couldn't find the canal because it was calcified. And another teeth, they found the canal, but then broke a K file, you can see here. And when you see the CBCT, you can quite clearly see that this is an incisive canal cyst. It's not an inflammatory lesion or an endodontic lesion. So there wasn't any need to do endodontics in any of these teeth. It was a surgical problem where this needed to be excised, and both these teeth didn't need endodontic therapy. However, since the endodontic therapy has already been initiated, you can see there's almost a perforation here. So the lesion was gone in labially, and this is something very easy with a microscope, by the way. If you don't have a microscope, then you don't really know which direction you're going. But with a microscope, you can clearly see the color changes here, where someone has gone in labially, and then there's a darkened area here. So you immediately know that this is where the canal is likely to be. By the way, if you've been around in this channel, you know that this is something I stress on. When you deal with calcified canals, it's much, much easier to do it under a microscope. And what you see here on the screen is something that any general dentist can do. So if you are a general dentist and you're someone who's curious about bringing in a surgical microscope in your own practice, then do check out my online course, Microscopic Dentistry Simplified. It's very easy. I've designed it specifically for general dentists. You can buy a microscope, bring it in your practice, and then learn how to use a surgical microscope so that you can handle calcified canals like this in your own practice. Do have a look. I've put the link in the description below. What we did, we knew that this is where the canal is going to be, and I found out the calcified canal there. And then you can see here, we obturated that tooth, and then we moved on to the next tooth. And in this case, the instrument's fractured way towards the apex, so it would probably be a bit of an overkill to remove this. The easier thing to do was to bypass this, and I managed to bypass this very easily, and then obturated that tooth as well. Now, once that is done, this is the pre-op and that's the post-op. The initial problem of the patient is the cyst itself, right? It's an incisive canal cyst, so it's a surgical problem. So this is something I don't want to do it in my practice, so I bring in an oral surgeon. I refer this case to my friend Dr. Anjan Shah, who's an oral surgeon in Bangalore. And Anjan sent me this picture from his clinic, and you can see here, that's an incisive canal cyst, which needs to be dealt with surgically. So in summary, what are the things that you as a dentist, as a general dentist can do in your own practice when you get a case which has a periapical lesion? Well, if there is an obvious endodontic cause for the apical pathology, then treat it endodontically. And the good thing is that most clinical cases will fall in the above category. Just remember, when something out of a routine shows up, involve an oral surgeon and an oral pathologist. Ask them, especially if you are a young graduate or even an established one for that matter, if something feels different, if something shows up in your clinic and some sort of instinct tells you that this is not something common, this is something different from what you see normally, then don't be afraid to ask for additional help. And it's extremely important for the endodontist to work closely with an oral surgeon. The oral surgeon needs to be aware of what is possible endodontically. Similarly, the endodontist too needs to know what is possible surgically. So both of them need to work in tandem. You have surgeons on one side who want to treat every lesion surgically, and on the other hand, you have general dentists and endodontists who want to treat every lesion endodontically. So one needs to have a balance. One needs to understand, the surgeons need to understand what can be done endodontically, conservatively for large lesions. On the other hand, the endodontist and the general dentist as well need to be aware when they see a case, they need to be aware which cases don't follow a set pattern and when you need to involve the oral surgeon. So it sort of should be a teamwork rather than sticking to their own corners. And as I keep stressing, the most critical factor in recognizing the outlier is often the experience of the clinician. So a clinician who has been around for a few years will be able to spot these outliers far more easily than a beginner who's just starting to work in clinical practice. So one needs to always ask for additional help if you see something which is beyond the scope of your expertise or your experience. That, in a nutshell, is the purpose of this short video. If you enjoyed that content, then maybe you would enjoy my weekly newsletter, which is a short email that I send out every Wednesday. It's usually filled with some useful dental and non-dental information. I've put the link in the description below. Do have a look and subscribe to my weekly newsletter called Wisdom Wednesdays. Don't forget to click on that subscribe button so that you get notified every time I upload a new video, which is usually every Sunday. And if you enjoy content like this, then maybe you should check out some of my other videos on this channel coming up over here. I'll see you next week with another video. Till then, take care. Thanks for watching.